Good afternoon, everyone. My name is Tracy and I'm the Community Engagement Manager with the Irish Motor Neuron Disease Association. So just to say welcome to our event this afternoon to everybody here in the room with us. Great to have so many sharing in the day. And also we are doing a live stream on our YouTube channel. So hopefully we have plenty of people watching in there as well. So on behalf of IMNDA and the Academic Unit of Neurology, so thank you for joining us on Global Awareness Day. 21st of June, the summer solstice is seen as a turning point seen as a symbolic turning point for the MND community around the world. It reflects the hope we all have for a turning point in the search for the cause, treatment and cure of MND. We're going to hear later this afternoon from Professor Orla Hardiman and several members of her research team in the Academic Unit of Neurology on the various research projects that they are currently involved in. There will also be an opportunity afterwards to speak to the researchers person to person. Also at the back of the room, there are poster boards showing the details of the various projects that they're involved in at the moment. And there are very many projects that they're involved in. So I'll let them give you all the details on that. We will be doing like a question and answer session. So we're going to wait until maybe the first bulk of the talks are done, and then we will answer any of your questions. Anybody that's watching on YouTube and wants to ask a question, you can do it via the chat function. So we then, obviously Gareth, our photographer, is here in the room taking photos. So just to make you aware of that, if you don't want your photo or your image to be used, just notify myself or one of my colleagues and we'll make sure that that doesn't happen. But hopefully you'll be happy for us to use them in any of our future publications or at any of our events. Now, you never know, this could be like Ireland's next top model. You don't know where you're going to get discovered. So just smile, get that look on the face for Gareth. Before we start with the talks, Deirdre here is going to give us the very important safety announcement. So over to Deirdre.
Hello everybody, you're very welcome. So as if I don't have enough jobs, I'm also the designated safety officer for the day as per Trinity requirements. So just to let you know that if we have a fire, we need to follow the fire exit signs, the green ones hanging out of the ceiling, to the fire assembly point, which is on Cumberland Street North, which is basically out on that side of the building to the left when you go out the door. So hopefully we don't need to do anything like that. I know that a lot of you have already found the toilets and where they are, but they're basically, if you haven't, they're just across that balcony and in through that wooden door and on the right hand side. And if you find yourself at a door where it needs swipe access, there should be plenty of us from Trinity around that can swipe you through a door. Don't be afraid to ask for help. If you're entering the knowledge exchange or back out onto the corridor with the lifts, you might need to swipe your hand over a green button. So again, there should be plenty of us around to give you a hand, but if you're there and there's nobody around, you should just rub your hand over the green button and you should be able to pop the door open. Don't be shy about this. There's still loads of buns and sandwiches and coffee and tea there. So just make sure that you're not hungry or having a sugar load at any stage during the afternoon. And just make sure that you ask any people from the IMNDA or any of us Trinity staff if you need anything at all during the afternoon. Just put up your hand and let us know. Okay, thank you. Enjoy.
Okay, so I think Maeve is going to be our first speaker. So just set up her presentation now.
Hi everyone, my name is Maeve Leahy and I am the Head of Communications and Advocacy at the Irish Motor Neuron Disease Association. And I'm going to take a very short minute, really short minute, I'm not going to be up here long, to discuss our sponsored silence, Voice for MND. Imagine an hour, imagine a day, imagine a week without your speech. Imagine not being able to say, I love you. Our voices are so unique. They're like our fingerprints. No two are the same. With their eyes closed, your friends and family know who you are by your voice alone. They're as unique and distinctive as our personalities. More than 80% of those diagnosed with MND will have or suffer from some form of speech deterioration, be that slurring of the voice or the volume or the amplification of the voice is affected, or unfortunately even complete speech loss. Back in 2015, we started the Sponsored Silence campaign with 2 fantastic women, Sharon Friel and Emma Fitzpatrick. Now, both these women had started blogs, and they were using words online to document their experience of MND, to highlight, I suppose, their everyday struggles. Sharon worked in the credit union and Emma Fitzpatrick worked in UCC in Cork. And a bit like our amazing ambassadors this year, Caleb Sheehan and John Daly, both teachers, they relied on their voices for their jobs, but not just for their jobs, like we all do in our everyday lives. I suppose it's that basic everyday things, the things that we take for granted. And we had often heard from people that they were feeling judged, that people were making assumptions on their character based on their inability to communicate. And people, we would have heard, making comments about being drunk and making assumptions that just weren't true. And we wanted to stop this. We wanted to change it. We wanted to do something about it. We wanted people to think and to understand. And so the campaign was born. So since 2015, our fantastic MND community have really supported and engaged with the campaign, and it's gone from strength to strength. Because of them, they let us use their words, their voices, their stories to, I suppose, draw awareness around this, to show the impact of what speech loss really has. Imagine an hour, imagine a day, imagine a week without your speech. We wanted people to not only empathize with those who were experiencing speech difficulties, but we wanted them to experience it as well. We wanted them to try look at the world around them and see how would they engage with it if they couldn't use their voice. What would they do? Would they use their phone, their iPad, a pen and paper? And that's really, I suppose, where the campaign, I suppose, grew roots and took over. So today is Global MND Day, the 21st of June, and we are marking it by making people be quiet. We're asking people to lose your voice so others can be heard, because sometimes silence can speak volumes. I'm going to show you a little video here now, but before I do, I just have a few thank yous that I'd like to make. One of them is to the incredible gentleman in the fantastic pink t-shirt sitting to my right, Caleb Sheehan. And also John Daly. You might have heard Caleb's radio advert that's actually going out across the airs at the moment on Today FM News Talk and Red FM, alongside Peter O'Mahony. And those of you who don't know, Peter Mahoney is a big fan up here, Munster and Ireland rugby player. But honestly, Caleb and Peter, the support was phenomenal. And we also had another ambassador, John Daly. And these guys did everything we asked, social media interviews, and went above and beyond. And I suppose, to go back to that, create awareness around the impact of the effects of speech. If anybody wants any more information on the campaign or has any questions, you can come up and chat to me, or you can go onto our website, imnda.e. Now I have a little video, so everyone cross their fingers and let's see if this works. Next, we've got Naomi Fitzgibbon, our Director of Nursing and Services.
afternoon, everybody. What a room. Like, it's fantastic. I started in the Irish Motor Neuron Disease yesterday, a year ago. And I just can't believe the amount of incredible work that has been done by the organisation. So what I'm going to do is just give you a little taster of some of the work that's been done, the highlights. And that's why these events are really, really important, so we can tell you the work that we're doing, but also how the money is spent as well, and how that is so important to us, that we're able to raise vital funds to do the work that we do. So very quickly, and if you can't hear me, okay, there you go. All of our work is evidence-based, and we're very clear about that. We have a very clear strategic plan that we follow, and we know that people living with MND and their families are the centre of our world. And we are part of that community that supports people living with MND. These are some of the highlights from last year. And as you can see here, it was a very, very busy year. We had an incredible number of nearly 19,000 support calls and emails. We had nearly 800 visits by the nurses to people's homes and within the community. We supported 120 healthcare professionals going out and educating them and telling them how to help and support people living with motor neuron disease. And totally, we had 560 people who got direct services from the Irish Motor Neuron Disease Services and from the nursing team, from the services team, from anybody, the information support team who work within the organisation. Also, not just the clients and people living with motor neuron disease, but also 16,000 healthcare professionals engaged with us, whether they wanted to know what kind of support they could get, wanting to know what kind of equipment they could get, we were there to answer their calls. Nearly 800,000 euros was spent on equipment, which is a phenomenal number. And that comes directly from the funds that are raised by events like Voice for MND. And just to show you then on the slide here, the current, well, not quite the current, this is a few months old, the number of people living with MND. And there's around 435 people that are living with MND today that we support. And not only the people living with MND, but also the families and carers and any healthcare professionals that is working with them. So our role is very simple: to improve people's lives living with MND, to avoid crisis, to maintain independence and promote autonomy, ensure dignity and enhance quality of life. And one of, I suppose, the biggest services that we have is our nursing services. And it is incredible that our nursing team are here today. You can take a look at these pictures, but they're actually in the room. So if you haven't met them, go and introduce yourself. Etna and Fidelma are the people that have been working, and Louise, in the organisation the longest. And our newest recruits were Moira, Catherine and Anya. So they're all here today. So please say hello and introduce yourself to them if you haven't met them. And these are the areas where they work around the country. And it is incredible now that we have a team of 6 nurses. When I started, we have a team of 4. So we are expanding, and it's just incredible. And they really are a unique team. And when people wonder, what do the team do? We are here from the moment that an MND diagnosis is made, for as long as we're needed. So our MND nurses are involved in the MDT clinics in Beaumont Hospital, in Cork, in Kerry, and within the community as well. We are integral to that community care and that all-round care, holistic care of somebody living with MND. There was an incredible fundraising event, which I'm sure you're all aware of, which was, Charlie Bird's Climb, which he did, and we were very lucky to be a recipient of his funds along with Pieta House. And we did a survey to find out what do people want to do with that money, because our services are all evidence-based. And what came back was that people wanted a 6th nurse. They want to contribute to research. They want to fund voice banking, and they want a recharge grant, a transport grant, and also to respite to alleviate the burden of care. And we've been able to do all of that, and we're just working on the last piece, which is the respite care. So as you can imagine, it's been a very busy year, but we're delighted to be able to do these programs and deliver the care and the services that you say you want. We've also been able to support research. We did a survey with MND Scotland, and that was a survey that was for people living with motor neuron disease, their families, and people who'd been bereaved. And we had a huge response. It was 340 people. So we're going to look at that research, find out what are the gaps in our services and how are we going to deliver the services that are needed around that. We also support the Trinity work as well, and that's just a few of the work. And I know that Professor Hardiman is going to be here talking about her research, and also the other researchers here will be talking about their own research as well. So we do have a little bit of a video as well. Unfortunately, Charlie Bird wasn't able to come today. He's on his holidays in Westport, but he did record a video, which I'm going to try and find for you now. If you just bear with me. And I need to exit that, Tracy, do I? Yeah. Let me just show you the little video and the message.
Sorry, now just 1 second.
The 21st of June is IMNDA Global Awareness Day, and we are here today to mark this and to talk about some very news to do with voice banking, which is especially poignant as June is Voice IMNDA Awareness Month. I'm very excited to say the Irish Motor Neuron Disease Association, the Charlie Bird Development Fund, is announcing that I Will Always Be Me, which is the book that banks your voice, will be in Ireland from today. People will be able to access this from the Speak Unique website. This will allow people with motor neuron disease to record and save their own voice to this platform for the future. As we mentioned earlier, June is Voice MND Month, and IMNDA raises awareness of MND. How 80% will experience some form of difficulty. Some will lose their voice completely. Awareness of this is raised through Voice for MND sponsored silence campaign that runs throughout the month. Today I am asked you to stay silent and up your voice for just 1 minute there at Trinity Biomedical Science Institute in recognition of all those who have lost their voice to MND. So let's all stand or sit together in silence for 1 minute and acknowledge people in Ireland, all around the world, who have lost their voice to MND. Thank you for giving up your voice for 1 minute. If you would like to give up your voice for longer and take part in the sponsored silent this June, you can go to imnda.ie and sign up for the campaign there. Today, the 24th.
Off again. And we're so grateful for Charlie for recording that for us, and of course for the funds that he raised in order to deliver those services. And lastly but not least, just to put a date in your diary, that the AGM will be on the 5th and 6th of October in the Hudson Bay Hotel, and hopefully we will be able to see lots of you there as well. Thank you very much.
Okay, we're going to now move on to the research team. So Conor Hayden is going to talk to us about clinometrics and explain what that means, because it sounds very complicated and technical. Megan.
Good. All right. Afternoon, everyone. My name is Connor, and I'm just going to talk to you today about an aspect of the research here in the neurology unit that I'm involved in, where we focused on developing objective devices for measurement of different functions. So first up, a bit of a background on me. So I'm a biomedical engineer. My PhD is in medical device design, and the project that we've focused on is developing sensitive and meaningful measurement devices for MND in two areas: hand dexterity and respiratory function. So you might ask, why did we focus in on these? Well, basically we want to be able to treat MND. To do that, we need really good measures. So for any new drugs or any sort of clinical trial development, we need to be able to objectively measure, so put a number on what sort of function we're measuring. However, at the moment, the current tools that are used aren't super sensitive. So anyone who's been involved in research might have, because I know I see a few familiar faces here, you might have seen or heard me ask sort of questions relating around your upper limb function. You might have taken part in research as well, where the gold standard at the minute is where we just assign numbers, basically, like on a 0 to 1 or 0 to 4, like a 1 to 5 scale. And they're just not very sensitive when it comes to sort of drug treatments. So I'm going to focus in on one device that we've developed, which is a dexterity device, so for your upper limb function. So we have you just see all the data that's being entered in on our SAFE app. It keeps it all safe and secure. And this test digitizes or puts a number on a test that's called the finger tapping test. So you start off with your index finger placed on the little line in the middle of your thumb, and you extend your finger as high as you can, as fast as you can. And our device attaches onto your thumb and your index finger. You do the test, and at the end of each test, you get a raw graph back. So you see the trace from your finger tapping test, and from that we can pull out a load of values like your height, your speed, your accuracy, and we can assign a 0 to 1 score. So 1 would be perfect hand function. And we've tested over 200 participants to date, 50 with MND, and we're happy to report the device works. It is able to return the values we want. We can see they can pick up differences between groups, but obviously we want to make it better, and we want it to be used outside of this research, because we don't want it to just not be used, say, when I finish up or I'm not around anymore. So the plan obviously is to commercialize the research, which is one of the great benefits of here in the neurology unit and working with Prof. Hardiman. And we've filed a patent, so that's basically just to say the device is novel and that there's something there to protect. And we also work with Enterprise Ireland, which is a state body that will give a bit of funding towards developing the device, like making it better and making sure that other research centres and other people can use it outside of my PhD. But obviously none of that would be possible without your support, both for volunteering for my research and any other research topics that you hear after me. So I just want to say thanks very much for that. And if anyone has any questions, feel free to find me after the talks. So, thank you.
Hi everybody, I'm Leslie. So I'm going to be telling you a little bit about the IMNDA PhD research program. So the 5 of us here are the newest research recruits in the Trinity department. And what IMNDA is all about is finding ways to use technology to advance neurological care, so specifically care for MD. Thank you, Tracy. So IMNDA is funded by a HRB grant, so what's called a Collaborative Doctoral Award, or CDA. And what CDA grants do is they equip teams of healthcare professionals or health and social care professionals to work together to do clinical research in their area, and then bring the outcomes of that research straight back to their clinical practice so that the individual can immediately benefit from the outcomes. So it's obviously great for the 5 of us to take advantage of that, but it's quite a significant grant as well for the neurology department here, It's worth 1.5 million and is currently the only CDA grant that's active in Trinity. And the reason why the AUN were successful in getting this grant is because they were able to build on the wide network of national and international expertise. So the application for the grant was made in collaboration with researchers and clinicians, both within and outside Trinity, and also with representatives from the M&D community as well. So Miranda was designed by this team of experts as 5 interlinked but individual PhD programs that are all focused on patient care. So the first project is being done by Avril, who's a physiotherapist, and Avril's working on what's called ALS Create. So this is going to be a digital platform that has exercises with videos or how-tos for using equipment or following exercise programs. So a clinician will be able to use that program use the platform to make an individualized program for somebody. So a person with M&D or their support people at home can follow that program on a smartphone app. Then Rory is an anthropologist and he has experience in healthcare research, and he's working on building what's called a knowledge bank. So Rory's going to be going to specialist M&D clinics and trying to figure out the factors involved in how healthcare professionals make decisions about what advice they give to people with M&D to help manage their symptoms. So then he's going to try and take that information and put it into an electronic resource so that staff who work in other healthcare settings maybe have less experience of supporting people with M&D can use it as a resource. Then Megan is an occupational therapist, and her project is focusing on the healthcare professionals. So what are the challenges that they face in providing care? So what are the things that support their well-being at work, or maybe what are the things that lead to burden or burnout or distress? So Megan's going to try and work out how do we best support the healthcare professional, because that in turn will translate into better care for people with M&D and their families. Then the fourth project is my own. I'm a speech and language therapist, and I know a lot of faces here because I worked for many years in the M&D clinic in Beaumont. And I'm building on some of what Connor was working on, of looking at how can we use devices to get more accurate measures of physical function. So for me, that's speech and swallow. And going to work on developing these devices so that people can use them themselves for home monitoring between clinic visits. So maybe we can shorten or reduce the frequency of the visits, and then also as assessment outcomes for clinical trials. So we can see if there's more accurate ways that we can see if drugs are having even a really small benefit. And then the fifth project is David. David is a physiotherapist, and he's working on a telehealth app called Tim on My Pathway. So some of you might already be using this app. David's going to work to optimize the app and look at the potential for it to work as two-way communication between the clinician and the person at home. So what Tim on My Pathway does is it sends a series of questionnaires that somebody fills out so we can keep track of how people are doing at home. And this can also help with us coordinating and planning clinic visits. So as you can see, we have lots of work to do over the next few years. And because these are all really patient-focused projects, we are going to be looking for input from the M&D community to help us in shaping these projects. And when Avril talks in a few minutes, she'll tell you about how, if anyone's interested, you can get involved in that.
Hello, my name's Roisin. I'm an assistant professor here at Trinity College, and I work on looking at ways to research brain function in ALS or MND. I'll use the terms interchangeably. So you can see in this cartoon here that different areas of the brain are associated with doing different things or different functions. So in ALS research, of course, we're particularly interested in this area that's associated with movement, because there's lots of motor neurons in there and other related cells that help us to move. But we now know that some people with ALS have, or with MND have other problems, such as things like paying attention or planning or making decisions, which we call cognitive functions, or controlling certain behaviors, or problems with language, such as using certain words, or problems with things like feeling or sensing in our environment. And they're all represented or created by other areas of the brain. So these areas of the brain are generally not really looked at in ALS or MND, and we really want to better understand how they're affected. Also, all of these areas of the brain don't work alone. They're highly connected by these wire-like structures to form what we call neural networks. And so by understanding how ALS or MND affects these different networks, we can better understand why it causes the problems that it causes. So you might ask, why are we interested in looking beyond the motor neurons if the movement problems are the major issues we're experiencing? So some of those reasons are that if we can better understand overall what MND does to the brain, we can identify it earlier and give a more certain diagnosis more quickly. Also, if we understand how different people are affected differently in terms of their brain function, we could provide more personalized information in terms of what the person can expect to happen. And finally, we could use these measures as a readout to test for if potential treatments are working more sensitively, and also potentially to identify if different people need different treatments based on how their brain is affected. So how do we do that is the big question, and I'd just like to reassure you there's no needles, no blood involved. I see some people who've already taken part in the audience who can vouch for it being, I hope, a relatively relaxing or at least easy process to take part in. So we do what's called transcranial magnetic stimulation in one of our research studies, or TMS, to look at the movement networks. So in this, we apply magnetic pulses just over the head and measure how the movement networks respond to those magnetic pulses. And that gives us a readout of those areas of the brain. And then we also do something called electroencephalography, or EEG, which is where we just place sensors on the head and they measure the naturally occurring brain activity that happens in these networks as the brain does different things. And just to highlight that this EEG is not the same as the needle EMG that I hear very bad things about. So there's no needles, there's no blood or anything like that. We just measure what the brain is doing and how well it's doing its job. So just to give you a snapshot of what we've already managed to achieve with this work. So on the top, you can see, for example, we've identified 4 subtypes of MND. So within the Irish community, we were able to find 4 different, what we call clusters or groups of people within the overall ALS population, which have differently affected brain networks. And we're looking more into how that affects the medical outcome. And then also on the bottom, you can see that it's on the left, we have people without ALS, and people on the right, we have people on the right are people with ALS. And you can see that this little red peak is diminished or missing. And this is a brain wave that we know is involved in certain functions affected by MND. The interesting thing is we were able to show that this brain wave is missing even when the symptoms haven't happened yet. So this indicates we could use these measurements for earlier intervention, earlier detection of MND, when we're more likely to be able to be effective with drugs. So going forward, we're working on refining these measures in larger studies. We're looking at combining the measures to better understand subtypes of ALS based on how the brain works. We're looking at measuring if drugs are working based on these measurements in Irish clinical trials. And we're looking at testing if these measurements could even predict who will get ALS among people who are at risk of getting ALS. So I'd just like to thank everyone who has already taken part in the study, and people with MND and their caregivers who provide support. This is our team. Many of them are here, so please come and talk to us if you're interested, or you'd like to take part or have any questions. Thank you.
Hello, everyone. So my name is Emma Costello. I'm a researcher here in the Academic Unit of Neurology. And today I'm going to talk to you a little bit about some of the research that me and my colleagues carry out. And while Roisin talked a little bit about how we can see some of these changes in terms of the electrical activity of the brain, my research very much focuses on the functions of the brain in terms of things like memory, language, and how we maneuver in our environment. So motor neuron disease, we obviously think of it as a motor disorder, but there is, for some patients, they might experience some cognitive changes. So as I said, changes in maybe their language, their memory, their ability to plan and manage things in their environment. And this can actually affect almost up to 50% of patients. So it's not always seen as maybe the most important thing, but it can be an issue for some patients. What that typically looks like, so I'm sure many of you might have remembered this image from your clinic visits. we will sit down with you with one of these pen and paper tests. Hopefully this isn't re-traumatizing for any of you, but it's one of these short pen and paper tests that assesses the functions of the brain in terms of memory, language, and executive functioning. And this data is really valuable because it lets us know who is experiencing these changes and who isn't. And with that information, we can give you feedback or information that you might find will help you manage those issues. But the information is also really useful for our research in understanding the condition. So we can share that with our colleagues, like Roisin was outlining there, so that we can understand the association between breakdown in networks in the brain and how that affects our everyday functions. But we can also use it to potentially identify possible risk factors or potentially protective factors that might be able to stop some of these issues. Some of the drawbacks to these pen and paper tests, though, is, like any of you who come to our clinics, you know that it can be a very tiring day, so you can get clinic fatigue. If some of you are coming from very remote areas or a long way from Dublin, that's obviously, again, a big challenge. You can be very tired from a long day of travel, or you might not be able to attend those clinics as frequently. And we're also aware Leaving Cert is finishing up this week or next week. There's a lot of anxiety that goes on with getting tested. Okay, so it's never nice to have someone sitting across from you asking you to remember something or to name something. So one of the things we're studying is a home-based alternative. And this uses a platform that's developed by an Irish startup company called Cumulus. And what they have is a headset that you can wear in your own home that will measure the electrical activity of your brain. And they also use a tablet where you can complete tasks of these functions like memory, language, and planning. So we're carrying out a short pilot study, a small pilot study at the minute, where we're asking patients to use this technology in their own home over the course of 8 months. And we're trying to see, are people able to use it and does it work well? And so far, we found that for the majority of patients that they are able to use it, so our adherence is fairly reasonable. And importantly, I know it's hard to kind of decipher these complex box plots, but the important thing is that the box plot on the top is very similar to the box plot at the bottom. So our home-based assessment is giving us very similar data to our pen and paper tasks, which is what we want. And we're able to do these assessments at home over time. Okay, so the fact that a person is doing it at home, it means that they can sit down multiple times a week and do it, rather than having to do it once every 4, 5, 6, 7 months. So it gives us much more frequent information. So that's obviously just a very small snapshot of a lot of the research we're doing. But if you have any questions, you can email me at this email address, or I'd be happy to take any questions afterwards. Thank you.
Hi, I'm a bit small for this microphone, but can you hear me? Hi, I'm Julie Kelly. I'm CEO and founder of a company called Neuropath Therapeutics. And if I can find the right buttons here, where am I going up and down? Yeah. And we're developing innovative drug treatment for patients with ALS or motor neuron disease. I have 2 hats, so I'm a founder and CEO of Neuropath, but I'm also Research Associate Professor in Neurology here at Trinity, working alongside Orla. So Neuropath is a biotech spin-out company from Trinity. Our therapeutic strategy is directed really at harnessing what are extraordinary neurotherapeutic actions of something that occurs naturally in everybody's brain called the thyrotropin releasing hormone, or TRH for short, signaling system. And we're harnessing this for the treatment of ALS MND. Neuropath compounds actually are designed specifically to selectively activate the signaling pathway in your brain. And this will deliver, we hope, multiple neurotherapeutic benefits that impact really core aspects, as you'll see as my talk goes along, of ALS MND biology. This technology really was discovered as part of my academic research that I carried out at Trinity, here at Trinity. And with the discoveries, we licensed the compounds to Neuropath Therapeutics, and we set up Neuropath Therapeutics really to support the translational development of these compounds, to bring them really from the lab bench where they were being discovered through to the clinic. And in fact, we've been very successful at translating a lead compound, taking it from the lab bench upstairs and bringing it through all of the development that's needed to actually enable it to enter a phase 1 clinical trial. This particular compound has been awarded orphan drug designation for ALS by both the FDA and the EMA. I think perhaps I'll just talk a little bit about the challenges really in developing drugs for MND. And the challenge really is we don't know what the actual root cause is of the disease. It's not like you've got a bacteria growing and you say, okay, in order to treat this disease, all we have to do is kill that particular bacteria. In fact, the disease is underpinned by a very complex interplay of risk genes, aging, and the environment. And these all come together to trigger really what are pathogenic processes, disease processes that occur in the cells to make this motor neuron and other neuronal cells very unhappy. And all of these, there are multiple things going on. As you can see on the left-hand side of the slide, there's all sorts of things that are going wrong there with the cell. And this all comes together and leads to the death of neurons, the loss of neurons, and network degeneration, really. The neurons all talk to each other in a network. This is what Roisin's measuring the function of. And you get network disintegration where they're not able to talk to each other with the same efficiency. And this leads then to the motor functioning loss, and also in some cases into changes in cognition. So if I just go back and you think about all the things that are going on the left-hand side of the slide, what we've tried to think about is how are we going to, as a drug developer, how we're going to stop these things happening. So we're coming to recognize, much as the same as the way it's been come to recognize with oncology and cardiovascular disease, that if we could actually find drugs or find combinations of drugs that actually target a lot of those processes over on the left-hand side, then we'll might have therapeutic benefit over one drug that targets just one thing at a time. And you might imagine that this could conceivably be done with a cocktail of drugs. So you bring a lot of drugs together, each one targeting one of the pathogenic mechanisms. But more advantageously, it would be nice to be able to use a single multifunctional therapeutic agent, one that's able to tackle multiple aspects of the disease processes that are going on. And in fact, the target TRH signaling system in your brain is remarkable in this regard and highly relevant to the treatment of ALS, in that it actually has multiple benefit over multiple processes that are going on in the brain, leading to reducing those motor and cognitive deficits. And we've taken the lead compound just to make sure that it does what we think it might do on the tin at a preclinical level, and that's all been very successful. So this is where we are. We have taken it from the left-hand side where it was discovered in the lab, and we've taken it right through all of the preclinical bridging studies that need to be done and all of the regulatory prescribed studies that need to be done to enable us to enter into a phase 1 first-in-human clinical study. And it's proved to be very safe, so we have a green light now into heading into the clinic. And as you'll see from the poster over there, you can see that we're now trying to raise funding in order to enter those into the clinical phase of development. So we're strategically trying to find partners and funders to enable us to do that. We've a ways to go yet, as you can see, before you actually get to market entry, but hopefully we'll achieve the goal of bringing what is a very exciting TRH-based neurotherapeutic to market for the treatment of MND. I think the landscape is looking promising, not only for our drug development, but also with recent approvals by the FDA of drugs coming through the pipeline for the treatment of MND. So I think ultimately this is all going to look more promising than it has in the past. It's obviously a long process. It's a very expensive process. And I'd just like to thank all of the funders really that have funded us through this journey so far, which includes the HRB and Enterprise Ireland, the Wellcome Trust, and of course, Research Motor Neuron. The Atlantic Philanthropists have funded that translational research. As you go on through all of these steps, it gets more expensive as you go along, as you try to get to our clinic. I'd also like to thank all of my colleagues at Neuropath Therapeutics who've supported this journey, and all of my colleagues in the Trinity Motor Neuron Disease research team who are always there with questions and support throughout this journey. And just as it takes a village to raise a child, it takes an army to develop a drug. I can't really mention individuals by name, except I'd just like to call out 2 people in the audience who are just sat next to each other, fortunately. That's Gillian Slater, who some of you may know as the lady that takes the blood on a Thursday, but she has been through this whole journey with me since the 1990s and been very much part of the drug development team. And Roisin, more recently, has been giving her input to this project. So just like to thank them. But most of all, I'd like to thank Prof. Hardiman, who's been there from the beginning, has given enduring support to this whole journey, and hopefully will be with us till we get to that market entry point. So, and I'd like to thank you for your attention, and thank you to the organisers for enabling me to talk today. Thank you.
Hi everybody, my name is Avon McTague. I'm here. Is that okay? Oh, God, it's so low. Oh, hi everybody. My name is Avon McTague. I'm a physiotherapist by background, and I'm also one of the IMNDA PhD students that you heard Leslie speak about earlier. Now I'm going to speak about public and patient involvement. Oh, here it is. Okay, so I'm just going to briefly just talk about what patient and public involvement is, why it's important, what does it involve, and then that we're having an opportunity today to register your interest if you'd like to take part. So what is patient and public involvement? It's shortened when you see a lot of people talk about it as PPI. It's where you have an involvement in research with or by participants rather than to, about, or for participants. The Health Research Board in Ireland define PPI in research as public is everyone in Ireland who has an interest in health and social care. They define the patient as anyone who uses services such as patients, service users, clients or their carers. And then they define involvement as active involvement between people using their services, carers, general public and researchers. But what it's not is, it's not about providing individual data for research projects or recruiting people for research projects. So why is it important? So the reason why we're speaking about it today is obviously it links quite nicely with the theme of a voice for MND. So it gives people an opportunity to give your opinion in the research that is currently happening. It's an opportunity to give your opinion and your perspective on your lived experience of the condition. And it's about creating a partnership between the research team and participants, which ultimately leads to better, more meaningful research. So what does it involve? So as you can see here, the cycle here on the left, so you're right, shows you the cycle that a research project goes through. So it's about identifying and prioritizing research areas, undertaking the research, and then right through to where you're sharing your findings. So with patient and public involvement, it's very much specific to the research project in question, and it can happen in very many different ways. So it can be about identifying research priorities, about reviewing research material within the research. So that could be information leaflets, and then it can also be about sharing the findings as well. But it's really that opportunity to give your perspective and your experience of the condition. So what it involves is it can be a number of group meetings per year. They could be virtual or in person, but you don't need any prior knowledge of research to take part. We're also looking at levels of involvement. So if something like attending a group meeting doesn't suit you, you can look at providing feedback in a number of different ways. So this is what a PPI advisory panel might look like. So you'd have people living with MND, caregivers, family members, members of the public with a special interest, and then patient advocacy groups like the IMNDA. So after that brief whistle-stop tour, are you interested in taking part in our PPI panel? So we're delighted to say that today we're looking for people to express their interest in taking part, because we'd really like, as you've seen from all the presentations that I've been giving, we'd really like your direct involvement in the research, and we really would love to hear from you. So if you would like to hear more about it, if you're here in person today, there are some sign-up slips on some of the tables, and then there's a sign-up place just at the back where you can sign up your interest. If you're joining virtually, so if you're watching on YouTube, you can email ashling@researchmnd@tcd.ie, but I know Maeve has kindly agreed to put the email address in as well, where you can register your interest. And then what will happen is you'll receive more information about exactly what it will involve. And so we really would love to get as much interest as we can. So if you would really like to take part, you can have a chat with myself or anyone else in the room. So I just want to say thanks a million for listening. Thanks.
Thanks to all of our speakers so far. And now we have Professor Ord Hardeman to give an overview of the research programme, including the Precision ALS initiative.
Thanks, Tracy. I'm going to speak off topic, if that's okay.
Do what you want.
First of all, thank you very much, everybody, for coming. It's a fantastic turnout. And being of advanced years, it's a time in my life when we reflect as well as look forward. Looking forward a little bit smaller, reflecting is a lot bigger. But I'm reminded today is World MND Day, so 21st of June, and I'm reminded, casting my mind back to 1994 when we set up the first motor neuron disease clinic, and the motor neuron disease clinic in Beaumont wouldn't have happened without the Irish Motor Neuron Disease Association. So we have grown together from a triumvirate, myself and Etna Frost, who was the founder of the IMNDA, and Bernie Core, who can't be with us today, who was the first specialist nurse for motor neuron disease. Three of us in the clinic to look at us now. So we've over 50, I think, or 60 people working, spending their talent and their life on motor neuron disease, and that's a fantastic reflection of the partnership that we've had over the years with the IMNDA, and we're very grateful because we wouldn't be here today if it hadn't been for the IMNDA. So first of all, thank you very much to everybody in the IMNDA for believing in us and supporting us at the very beginning when we were just young and I know girls don't be callow, but we were young and the female equivalent of callow, and not very sensible and not very wise, and had to grow and learn. over the years. So the clinic now, it started out monthly and now it's weekly. It's 4 out of 5 Thursdays, and probably met most people here because we look after over 80% of people in the country. We see them in the clinic, and in partnership with the IMNDA, we effectively look after everybody in the country now with motor neuron disease. And the clinic has been a clinical care program, but linked all the way along with this view or this desire to make a difference, this desire to embed research into clinical practice, and that's been our ethos all the way through. And I don't know if anybody here has ever tried to get money out of the HSE, and actually in my day it was the EHO, no, it was before that, it was the Dublin Health Board, the Eastern Health Board, and then it became EORHA, and then it became something else, and then it became the HSE, and now it's coming back into a regional. But anyway, they tried to get money out of the Department of Health of the HSE to fund clinical care and to fund research is really difficult. But I'm really pleased to say that about 4 or 5 years ago, and again through the actions of the IMNDA and some of the really fantastic advocates that we worked with over the years, including the late Father Tony Coote, but others as well, and Colin Murray in the past as well, and more recently the late Roy Taylor, and many other people, Charlie as well, but everybody here in the room, everybody here is among some hero in this regard. And we were able to build research and build a business case to convince the HSE that a rarish disease where we have the smallest number of people in the country at any one time is deserving of the appropriate care. And over the years, 5 years ago, we got the clinic half funded, and this year we've got the entire clinic funded. So everything that happens in the clinic now, all of the clinical people, the clinical team, the Deirdre and her colleagues, as occupational therapist or physiotherapist or dietitian or psychologist or speech and language therapist or medical social worker, and our nurses are all now fully funded. We started out, IMNDA helped to fund how we managed the clinic because nobody else would give us money, a little bit of money from industry. But now the clinic is fully funded, so it's going to be sustainable in the longer term. And we're on our next generation of young professionals as well. And you met them. You met the next generation of young professionals that we're training. So the landscape in terms of the clinical care that we deliver in partnership with the Motor Neurons Association is strong, and that's really important because we need to make sure that that's going to continue on. Similarly, for the research, we started out here with me actually, and we got an executive officer, and over time we were able to build that into a very vibrant research group, and including people who are going to be permanent, including I don't know if Bavin is still here, but Bavin, who's funded from the Father Tony Coote Walk While You Can program, Miriam, I know Miriam is hiding. Miriam and Bavin are both members of our faculty now, both of whom their positions are directly as a result of the work that we've been doing with the IMNDA. So Miriam is actually, Miriam is in the blue jacket there. Look at her. But she doesn't like the limelight. But Miriam is actually in charge, and Miriam wrote the Miranda grant. That's Miriam's work is really important because Miriam's work is about living with motor neuron disease, about the experience of living with motor neuron disease, and Miriam is working closely with the IMNDA as well. So the research that we've done and we've built over the years, and the 50 or 60 people that we have who are engaged in research, and all of the clinical people that have worked in the clinics over the years and that we've trained and that we've brought on, and some of whom have stayed, people like Deirdre, who was involved in setting this program up. It's also part of the leadership in the Miranda program. Deirdre Murray, still know Deirdre. The research that we're doing in the clinic and in the university have given us an international profile, and it's not that unusual, but it's a little bit unusual in Ireland. So we're seen as world leaders in motor neuron disease research, and that's a fantastic reflection of our research team. And we've been lucky in recruiting really, really, really smart, best of the best people. Roisin is a very good example of that. A very bright girl that came to us in her second year of college, and you name the prize that's available in the university, Roisin has it. She's won everything that you could possibly win. We've also been able to poach people from other universities to sit beside, on the other side of Roisin is Dara, whom we stole from the College of Surgeons, and also part of the MANDA program. So we've been very lucky in recruiting people who are really, 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 really smart, and who've been able to put us on this international platform that has given us a leadership position in the world, in Europe and in the world. And that has also allowed us to attract in not only resourcing and funding, of course, very important, but also engage internationally in research. And we're part of a group called TRICALS, the Treatment Initiative to Cure ALS, which was a term that was defined by the Dutch, because they don't really speak English very well. It's horrible grammar. But I'm the co-chair of TRICALS. And TRICALS is a group of like-minded people, like myself and our group, who really want to understand the disease in people and not in mice or rats or small animals. So we want to focus all of our research and all of our understanding of the disease in the people who have the disease, and bring the new initiatives and drugs and development, such as what Julie is doing, into the clinic in a way that's meaningful. So, and our motto is the right drug for the right person in the right dose at the right time. That's what the motto of TRICALS is. So TRICALS is set up. It's centres. We're an exclusive club, and we don't make any apologies for that, because we only want the best centres in Europe in TRICALS, and we're the centres that see almost everybody in their region, at least 50 or 60 new people per year, and who have a track record in doing clinical trials. And our idea is to make sure that we do the trials properly, and that the trials, that the important trials come to Ireland. And Niamh, Cowell to Niamh, there you are. So Niamh is our, and Toyosi, our clinical trial team. And so again, we are continuously praised for the quality of our clinical trial team. Clinical trials can be messy and awkward, and people can do them in a very sloppy way. Not in Dublin. These two people are the two people I'm most afraid of after Bernie. I'm most afraid of because they make us do the trials properly. So if there is an important clinical trial going on in Europe, we will get it. We will be asked to be one of the centres, because we have a fantastic reputation, and that reputation is for three reasons really. One, we have an fantastic reputation. Two is because the people in Ireland, people here, are really great at engaging in trials and want to participate in trials. People who have the disease want to engage in trials, and that's not always the case. And three, because we have a really scary team that runs the trial really well and won't let us mess about. And so we have, I think, 7 trials underway in the event. Is it at the moment? Some of them are one of them is a trial we're doing with colleagues in TRICALS, so it's not a pharma-sponsored trial. It's a trial that of a drug called Trimec. The trial is called Lighthouse. The other 6 are trials that our industry have developed and have asked the community in motor neuron disease to engage in these trials and to bring the trials to the people that they look after and to participate. And there's lots of discussion around trials and how we include people into trials and what the outcome measures are. And that's what Leslie was talking about as well, to make sure that we have the right outcome measure for the right drugs. There's a lot of discussion underway about that, but it's if a trial is important, we'll get it, is really the message I'm giving you. The other thing is that Judy mentioned regulation, the regulatory approval of drugs. And we've been asked a lot of questions because people, the world is a small place now. And if the Federal Drugs Authority, the FDA in the US, approves the drug, there's an assumption that the drug works, and that B, that we should get the drug. So there's a lot of politics around drug development, and particularly around drug approval. And there's a discordance between the FDA in the US and the EMA, the European Medical Agency, and the Regulatory Authority in Europe. And I have to say that the view in Europe is that the FDA has been is approving drugs in a way without enough data. So there's a drug, for example, by the company called Amylyx, and the name of the trial they're doing is Phoenix, that was approved in the US on very flimsy data. Similarly, a drug called edaravone, which was approved in the US and not approved in Europe, and we're doing additional trials. And the reason why we're doing that is because we don't want to give people drugs that don't work. So if a drug gets approved and the evidence that it works is very flimsy, we shouldn't be doing that. We shouldn't be giving drugs to people when they're not working, when we don't know that they work, or we're not sure that they work, or when they're unpleasant to take. So the edaravone, I forget the name of the trade name, but that was an intravenous injection every 2 weeks that was approved by the FDA. So what I'm saying is, we're as hungry for drugs that work as everybody in the room here on both sides of the table. But we're not going to advocate for drugs that don't work. We're going to advocate the drugs that we know are going to work, and we will do the trials to prove that the drugs work. And if the trials show the drugs work, we will be out there fighting the European Regulatory Authority and also the Health Technology Assessment here in Ireland to make sure that we get the drug to the person as quickly as we can in a cost-effective way. So you need to be aware that we are fighting very hard for that. The other drug that was approved in the US is a drug called tofersen. And tofersen is a very exciting drug because it does look like it really works. But the problem with tofersen is that it's a gene therapy drug, and it only works for people who have a particular gene that's associated with motor neuron disease, and that gene is called SOD1. It was the first gene that was identified in motor neuron disease in 1994. And SOD1, the discovery of SOD1 allowed us to make mice with that gene in it. But it turns out SOD1 is actually a little bit unusual in terms of that type of disease that you get with SOD1. It looks a bit different. The other thing is that we don't have any people in Ireland that have the SOD1 mutation. We've looked and looked and looked. So SOD1 treatments, although they're really exciting in the field, they're not relevant to Ireland at the moment because we don't have anybody. We look for we ask for people with blood sample, and we do the gene testing on everybody now. We started doing that. The gene that is important in Ireland is a gene called C9orf72, and that accounts for about 10% of motor neuron disease in Ireland. About 50% of people are familiar with motor neuron disease. And we've done 2 trials with C9orf72. It's an injection of a gene, a gene that turns off the gene into spinal fluid. And those trials didn't work, unfortunately. So we don't yet have a drug for C9orf72. But we're still out there, we're still engaged, and we do trials in 2 centres, in Leeds and Tylosi's centre in Beaumont, but we also do more invasive trials over in St. James's and the Clinical Research Centre in St. James's. So all of this work that we're doing, our clinical work and our research work and our desire to engage in clinical trials that are better, have led us to sort of take a little bit of a step back to think about why are the drugs not working? And then Julie showed a picture of how complex the disease is. Why do we have so many drugs that failed? Because we've had 70 or 80 drugs that have failed over the since I've been doing trials, which is back from the last century. Started doing trials in the late 90s. So it's a long time not to have a drug. The drug that we have that works is Willisol, and it doesn't work that well. It does work though. So what is it that? Where are the mistakes that we're making? What are we doing wrong? And why can we find mistakes that we can keep on making so that we can find better drugs for that work? And one of the things we know now is that motor neuron is not the same for everybody. Everybody knows that who has experienced motor neuron disease. It's different. Everybody is different. There are different kind of strains of the disease, possibly different causes, as Julie said, and different factors that lead to how fast or slow it moves. And the idea that you might have one drug that works for everybody is probably very naive, in the same way as there isn't one drug that cures cancer. There are lots of different drugs and they work in different ways, and the cancer might come back, you might need a different drug. So we need to be a lot more sophisticated in how we think about this disease. And part of the sophistication means to be humble about how little we know about the disease. And one of the things that we need to do is to think about the people who have the condition as individuals, and try and understand the disease individually, and try and find better ways of characterizing disease in individuals. And Roisin mentioned a little bit of that with the brainwave testing that we're doing and looking at the different patterns in different people. So in order to do that, the idea would be that we kind of think about how we should think about how we think about the disease in the same way as we think about it if we were doing preclinical work, work in a laboratory. And we should be looking at people with the same level of the same depth of evaluation as we would do in a lab. So what does that mean? Well, it means trying to find out as much as we can about the person and everything that happens to them, all the things that might have happened before, and how their brain imaging might look like, how the brain wave activity might look like, what the work that Emmett is doing, the thinking might look like, what the blood work might look like, whether there are markers in the blood that might signal different subtypes of the disease in the same way there are markers in the brain activity. So in order to do that, we need to do that with a large number of people. And we need to do it in more than one country, because motor neuron disease is a rare disease. You need very large numbers. And we need to look at genetics as well. So we put together a project called Precision ALS, which is exactly what it says in the tin. So to try and understand motor neuron disease, or ALS as in name for it, from a precision medicine point of view. Precision medicine is a real buzzword in cancer as well. It's getting the right group of drugs, probably something more than one drug, to the right people. And in order to know if the drug is getting there and doing what it's supposed to be doing, we need a lot of more ways of measuring than we have been doing up to now. So Precision ALS is an academic industry partnership. So we approached a number of different pharma companies and other companies as well, and see if they'd be interested. And we brought together my colleagues in the ADAPT Centre, which is a big computational science. And I see Kira Amaras, who's our, she's over there, you're hiding in the corner there. She's our overall project manager. She's running the entire program from the ADAPT side. And then from the clinical side, we have ourselves, and then a group in RCSI, the College of Surgeons, of which I remember, called Future Neuro, which is interested in rare disease. So there are clinical colleagues here in Ireland, but also all my colleagues in TriCals. And we put this proposal into Science Foundation and said, would you fund this to allow us to really understand this disease and to build this platform where we can collect information from everything that happens to a person with motor neuron disease, everything that happened and things that have happened to them before if possible, and blood samples and brainwave testing and imaging and remote monitoring and technologies, and put all of that on a big machine, a big platform, a big data science machine that we're building in ADAPT, and allow us then in the longer term to be able to collect this information, so that we'll have lots and lots of information that we can then start looking at using the new technologies around machine learning and the dreaded word AI, to allow us to understand the disease in ways that are more that give us more information than I would be able to discern as a clinician. So Precision ALS kicked off last year, and there are a number of people in the room here who are leading out in this security one. But of course, from our point of view, the main man is Mark. So most people know Mark. Mark was running the register, our motor neuron disease register for years, and Mark is now running the sort of clinical side and bringing together all the people, with Anna in the back as well. Anna McDonald, she may have come across Mark and Anna. So Precision ALS, the objective is to have the right drug for the right person at the right time. So what we want to do is have enough people across Europe that we know enough about, that first of all, if a trial comes in, we can press a button and say, we have 500, 400, whatever number of people in Europe, including people in Ireland, who would be suitable for this trial, and we can ask them today would they be interested. So that would be valuable. But we could also, using the machine learning technologies, we could say, this person probably would be suitable because they have this profile, but this person might be suitable for another drug that we're developing because they have this profile. So the idea would be that we would have lots of different drugs for lots of different types of profiles, and maybe be able to run many different trials at the same time as well, because we might be able to generate sort of avatars, pretend patients from the data that we have on, so nobody would have to go on a placebo anymore. So that's the objective behind Precision ALS. It's been running for about a year. It'll be running for about another 4 years, and then I'm going to retire. If not before. And I'm going to retire because the environment is really healthy, because we have a pipeline of brilliant clinicians and researchers, so that I can ride off my bicycle into setting something like clarinet, my little grandchild. I'm not worried that because I go, that the research and the clinical program is going to end, because that's a big risk for people my age, that you go and it's going to founder effect. And that's not going to happen because we've been really careful. So we have an entire leadership program and an entire leadership group who are already leading, who will continue on in this program in longer term. So I'm really confident that in the next years we will have a menu of drugs that are going to be much more effective than riluzole. And I would love to have a situation where we have a drug that arrests the disease, that stops the disease progression, making it turning it back and making it better. That's a big ask, I think. But I think we would all be very happy to stop the disease progressing. All right. So I think that's what we're aiming for, and I'm really confident that over the next few years we will be able to do that, because we know the mistakes that we made, and we have a lot of really bright people working together now, both in Ireland but across Europe as well, as a team to make this happen. So thank you very much, and I'm happy to take any questions.
Thanks to Professor Hardiman and to all of the speakers. So I think it is fair to say that the future of research in MND is very bright, and it sounds like we're getting a lot closer to that turning point of the summer solstice that will bring much improvement to the lives of people with MND, and hopefully, as Professor Hardiman says, to be able to arrest the condition in its progress. If anyone in the room has any questions, our lovely Lisa has the microphone and will come over to you. Anybody on YouTube has a question, please type into the chat, and Maeve will make sure that it's read out for you. And maybe if our speakers might want to come up to the top, just in case there are any questions for anybody other than Prof. Hardiman. Thanks.
One other person I should mention, because I didn't see that, Francis is Mark's twin. Francis is fantastic from the data science side. So Francis should.
Any questions? Anyone? Not one? This is like a first for us to have such, I suppose, to any event with Professor Hardiman and the team, and not one question from the audience.
Okay, I'll ask a question.
Yes, ask. Hold on, Lisa, Mike.
You didn't mention genetics. We've got somebody studying on genetics.
We do. I should have mentioned it. We're part of a large collaboration called Project Mine.
Okay.
So what we do when somebody comes to clinic, we ask them for a blood sample. Now we ask them for 2 samples actually, and Janine quite soon will be asking them for more than 2 samples, because we're doing some work with markers. But we have a DNA bank. So we take a blood sample and it goes into our DNA bank. So everybody here, I think, has been in the will have given us a blood sample. And one of the very clever people who works with us is a guy called Russell McLaughlin, and he's a group of very clever people who work with him. And actually, Anna was one of those as well, but we snagged him over to us. Looking at the genetic profile and then doing research on genetics, and we trained another very clever fellow called Kevin Kennan, who we then lent over to guys in Utrecht in the Netherlands, but he's still one of ours. And so he's working on he's found a number of genes actually associated with disease. So Project Mine is a big project where we sequence the genome of people who contribute a sample. It was expensive when it started. It's become a bit cheaper now, and we do a lot of research looking at genetic factors, and then looking, and there's a project now as part of Precision S. We'll be looking at the genetics and then the very detailed characterization that we're doing in Precision LS. So genetics is part now of Precision LS, but we do our own genetics as well. Now we've started in the recent past asking people for another sample, and we offer to check everybody now who comes to the clinic for known genes. We didn't used to do that, but there are some clinical trials now that are related to particular genes. C9orf was one of those, SOD1 was one, but there will be some others. Another very rare mutation called FOS, and there's a clinical trial for that gene as well. So we offer people now that we can check and see if they have one of the known genes. And we hadn't been doing that up to now because it wasn't a treatment, but we're doing it now.
Okay.
But we also do research. So Russell's group has a big research program in genetics and motor neuron disease as well.
Can I just say one, sorry, it's a second question, but if you know that in generations gone back, that there has been motor neuron disease, or indeed Kennedy's disease, which is one of the motor neuron diseases, is it advisable to go with younger children to try and get them assessed at this stage?
It's a really good question. So it depends on the gene, actually.
Yes.
So Kennedy's disease is slightly different because it's on the women don't get it, but they pass it on. It's called an X-linked. So men get it, but women pass it on. So a man who has Kennedy's disease, if he has a daughter, she won't get it, but she can pass it on to her son.
Yes.
So Kennedy's disease, it's very clear what the inheritance pattern is, and it's very clear that if you have that variant, the probability is that you will get disease. For almost all of the other types of motor neuron disease, that's not the case. You may carry the gene, you may never get it. You may never get the disease. We also know that there are associations, and this is some of the work we've done over the years, between motor neuron disease and some other conditions as well, that we sometimes think of that as being developmental. So we see a little bit more people with a little bit of other psychiatric conditions within their families, a little bit more frequently than you would expect. So our view at the moment is that I'm cautious about suggesting that we test for genes in family members at the moment, mainly because I don't think we can give people a very accurate perspective on whether they're going to get the disease or not if they carry the gene. The National Centre for Medical Genetics in Crumlin does have genetic counselors, and they are beginning to see people families members, and I've been discussing with them about the sort of information that we should be giving, because what's written in the literature is actually incorrect about the probability of getting the disease if you carry this gene variant. Part of the program that we've just got funded for, which is going through the bureaucracy in Beaumont now, is for a genetic counsellor, and so we will be ramping up that program over the next couple of years for genetics, so that we'll be able to advise people properly with a proper counsellor about what we should or shouldn't do in terms of discussing risk with family members if somebody is known to be a gene. Does that answer your question?
Absolutely. Thank you ever so much. Thank you.
Firstly, I'd like to say thank you, Professor, and to all your team. You do a great job. Thank you for today and for all you do for us. And my question might sound like a crazy one, but do you think in the future would there be any research into reversing what's happening at the moment? Is that a possibility?
I think it's a really difficult one. I don't want to sound negative, but one of the problems is that the way our nervous system works, we don't really understand very well, and how the pathways stop working is not very well understood at the moment, and trying to reverse that, we'd have to have an awful lot more information about the engineering. It's not to say that there mightn't be technologies that could, if say for example, we could stop the disease from progressing. There may be technologies that could override that. You see this in the paper. There's something last week about exoskeletons for people who and Elon Musk, of course, is going to fix everything for us by putting chips in our brain. But there, the field of robotics is developing, and actually, Bahman, who's I'm embarrassed talking about how the nervous system works, because Bahman is a neural engineer, Father Tony Coote, assistant professor, is an expert in this area. And I think, would you agree with me, Bahman, that it's really complicated, and to try and reverse it at the moment from an engineering point of view would be quite difficult. But there may be technologies that could override this with clever people like Bahman, that we can get the system working again, but not with the nervous system that's there, but with using clever technologies that the engineers develop. We in the last few years in our academic unit, I think we've hired more mathematicians. They're all standing there at the back. You see all those 4 people there? They're all really, really, really clever mathematicians. They're so clever. They're really scary, actually. But we've hired a lot of mathematicians and engineers, and colleagues and engineers on, actually, because they're the people who are going to help to solve this problem for us. It's looking at this thing from an engineering and mathematical point of view. Would you agree, Bahman?
Yes, it's a very challenging. So I think probably in the first place, just how the progression, the first reversal is even more difficult, because as you say, how the communication in the nervous system occurs, it is finely related to how it generates everything else. And even that piece of knowledge is not really known to us, so it's much more difficult for us to tailor it, guide it, and adapt it in a way that can lead to stop of the degeneration process and then reversal of that. But we keep the hope. So so to be able to engineer or to modulate or affect, manipulate, in simple terms. So we need to know how it works. So if we don't do that, so we can still do trial and errors, just doing random things, trying to see if stimulation works, or just double stimulation works, which is worthwhile efforts. But my personal opinion is that we need to first understand how things work and then try to make the reversal. So that's my take on it. Thanks.
I would put my money on him, though. I would put my money on him.
Hi, just firstly, thank you. This is a little bit of we've just recently, my husband diagnosed, so it's all very overwhelming and a lot of information, but it's wonderful to see how much work has been done and how much you are doing and planning to do in the future. It's really gives us a lot of encouragement. My question was that one of the aspects I find really difficult is not having a roadmap and knowing what lies ahead. Is there research into an understanding into why the disease manifests itself in different parts of the body initially for different people, and the speed of progression, and how that is so hard to understand in terms of the future outlook for an individual patient?
Yeah, it's a really good question, and it is one of the questions we want to answer at Precision ALS. So there are, and I think we mentioned this when we see people in the clinic, there are some things that we can use to predict, how fast a certain thing is going to progress. They're not very good. I mean, we are looking at mathematically building this sort of model that Mark is leading out on that with some of the ALS, with some of the Precision ALS people, to try and give people some kind of sense of where things might go and how fast it might go. But I think it's the reality of the situation is that it is quite difficult to predict because people are different, because the disease is heterogeneous. It's not the same. So trying to unpick the heterogeneity and trying to classify people into different subgroups that are the same, that's been very challenging, and that's what Precision ALS is about, is trying to do that, so we can give people some kind of sense of the subtype that they have and the types of treatment that we might want to look at. So we have some indicators of prognosis, my colleagues in the Netherlands have built something called a prediction model about the length of time somebody might have. I'm not a big fan of using that in a clinical setting because, first of all, it's a probability-based thing. And secondly, it's not particularly helpful in my opinion. If we want to do clinical trials, it's very useful. But I'm not sure that it's very helpful on a day-to-day basis because it's a probability, and the probability is only a probability. So I think we have to separate out what we do from a research point of view from what we do as clinicians, and what we do as clinicians is we do our very best to walk the walk. But if somebody has a very rapidly progressive form of the condition, we will tell them. I think it's dishonest not to. If somebody has a slow progression, we'll tell them as well it's dishonest not to. I think the best thing that we can do in this condition is be honest with people, and then we can trust each other, and we can walk the walk. So we can tell you, what the factors are that we think make this a slightly better or slightly worse form. But I'm not a fan of giving people the prediction model and figuring out, well, you have a 50% probability of survival for 5 years. To my mind, I wouldn't want that to happen to me. I wouldn't want any of my family to have that. I think it's not helpful.
I just have a question about medications. So, for example, if you're on a clinical trial like Amylyx, obviously you have to just take one drug because you just want to look at one variable. But obviously that's very patient-centric, but it's also important to clinicians and researchers that you would just stay on one drug or one variable. But obviously there are lots of other drugs available. So what is, if the person was to take a number of edaravone and tofersen, a number of different drugs, like a scattergun approach, what's the negative to doing that for the patient?
Well, I wouldn't recommend Amylyx and tofersen at the same time because tofersen only works for SOD1. So, but it's a really good question, and it is that trying to it's trying to separate out the desire to treat versus the scientific requirement to know. They're the two different things, and so for us to engage in clinical trials, to know if a drug works or not, we have to know that the person is taking the drug, number one, and secondly, there aren't any confounding drugs that might make the drug less likely to work or more likely less likely to work, actually. There isn't any treatment at the moment for which there's definitive evidence that the EMA recognises except riluzole. So Phoenix or Amylyx has just got an initial less than positive opinion from the EMA as what would be called an early conditional approval. So the EMA didn't really believe the data that the FDA approved. So the other thing that we need to be very careful about is the idea that we do harm. So using drugs that are off-label, all drugs have side effects. If you read the side effects of an aspirin, you'd never take an aspirin because it can kill you. So we need to be very careful about using drugs that might look fairly innocuous, but could do damage. So I'm a little bit cautious about that, about what we call off-label treatments, and it's actually born out of experience because there's made many false starts for drugs for motor neuron disease. And a very good example is lithium. Another was topiramate, both of which are drugs that were so-called repurposed. And there was a very small trial of lithium suggesting that lithium improved outcome. And so there's a lot of pressure on people to prescribe lithium. We came under a huge amount of pressure at the time to prescribe lithium for people. And it turned out when the trial finished that people on lithium did worse, that people on lithium had a faster progression than people who weren't on lithium. So if we had prescribed lithium, we would have injured people. Similarly for topiramate, it's a drug for epilepsy, and there was a trial, and we're under pressure also to prescribe topiramate. There's another drug for epilepsy that was under trial, and actually one of my colleagues in the US was prescribing off-label, and it really annoyed me because she was prescribing people in Ireland off-label as well. And it turned out the drug was taken off the market for safety reasons. So I'm really cautious about that. We should be really careful about what's called polypharmacy, about giving drugs, multiple drugs, in a situation where we don't really know what the drug is doing. And also, I'm terrified of Tylosi. So, so even if I did, I'd get really into a lot of trouble. So and Tylosi is right, and Neil, because we shouldn't be doing this, because we can't know if the drug works or not if we have other drugs that people are taking. But I completely understand the position that you take, that I'm the one who has a condition and I'm willing to take the risk. So we have to take the view, and it's the same issue that's very alive in the US. It's not as bad here. Irish people are very sensible about the so-called right to try. So it's my body, and I have the right to try drugs. So you should give me the drug because I have the right to try it. And so this is what's driven the FDA to approve drugs on a bit dodge. And in my opinion, that's very anti-scientific. So we have to tread this really difficult line of saying, well, as a clinician and a clinical provider and a clinician scientist, the science of this doesn't support what we're doing. But on the other hand, as an advocate for people who have the disease, I can really understand why people might want to do this. But if we want a drug to really work, we need to know the drug really works, and we should be doing the trial in a rigorous way. And the trials are for either 6 or 9 months. And if we put people in trials early enough, there's a possibility we can do the second trial as well. So, and often if people are on a trial, the drug is effective, the person can be on the drug after. It's called an open label, where everybody goes on the drug. So the trial might be 6 or 9 months, and then everybody goes on the drug afterwards. So the advantage is being on a trial, even if you're on a placebo, or being on a trial of a drug that mightn't work, as long as you're being carefully monitored, because there are side effects of many of these drugs, and we don't want to injure people. And that has happened in the past. So, does that answer your question? I do understand what you're saying. No, I'm not. I have a lot of sympathy for your position, I have to say.
Sorry, we just have one that's come in, and it's from Mark, and he says, it seems to me that falls is a key metric for progression, but also a key hazard for MND sufferers. Any thoughts about the benefits of teaching practical dynamic risk assessment for patient movements?
Okay, I'm going to ask a physiotherapist.
Can you repeat the question again?
Forward here. David. I'm going to share with David. David, get up there, you have to answer as well.
Yeah, sorry, I'll repeat it.
David, up there and answer that as well. Because your boss is in there, and then we have grown-ups in there as well. We'll ask each other.
So it was like false.
Yeah, I'll repeat it again, and this is from Mark, and it says, it seems to me that falls is a key metric for progression, but also a key hazard for people with MND. Any thoughts about the benefits of teaching practical dynamic risk assessment for patient movements?
Yeah, well, I suppose it's online. So he means by practical risk assessments?
Yeah, I suppose like if you see somebody progressing in a certain way and if they're falling, is there a way for them to, I suppose, assess their movements and maybe their environments, like do a risk assessment on their own movements and homes to prevent against it? Now I'm putting words there, so sorry, Mark.
So Mark can type back in if you
yeah,
answer that.
exactly,
Right?
yeah.
Well, I suppose as physios and occupational therapists would definitely have a role that if people are noticing that they're tripping or falling more, from a physio point of view, we would always assess people's movements and strengths, but from practical strategies, we'd also be looking at things like adapting walking aids, any other adaptive aids that might be needed, as well as strategies about getting on and off the floor. I'm not sure if that's what he's also hinting at.
Yeah, apparently I did a correct interpretation there, so.
Right. But the other part is.
I think that is bread and butter of what I do in the clinic every Thursday night. I look at people, I assess muscle strength, and I'm more like a salesperson off in the clinic than a physiotherapist, because what I like to do in the clinic is do a muscle strength assessment, a walking assessment, and try to find people who might be at risk of developing a risk of falls over the next couple of months before I see them again. And then I'm trying to sell them some kind of a walking aid, a stick,
you know, that rollator that the community physio gave you, I really think you should start using that now, because what you don't want to do, that person is absolutely right. It's a massive risk. You know, if you're an adult and you fall, it's a really abnormal, unnatural thing to do. It's a horrible experience. It knocks your confidence. You could be really badly injured. You can end up in hospital. The last thing you want on top of M&D is a broken hip. You know, that's going to absolutely be a total disaster. And that is totally the focus from the practical clinical management for an occupational therapist and a physiotherapist, is to try to stop that happening. And we can't always stop that happening. So I had somebody recently who was with me in the clinic on the Thursday night. I gave him the splint, I gave him the stick, I gave him the advice. And then I got a call a week later to say the man had fallen twice. And when I rang him up, he said, well, a lamb went up a hill and I climbed up the bank to get the lamb. And really, there's nothing that any of my splints and that can do to kind of be of use in that particular scenario. So there's always that thing of having to kind of educate people a little bit about, you know, you kind of have to be careful, and you do have to risk assess. Absolutely, you have to risk assess. So all the physio and splints and sticks in the world are not going to stop you falling down a bank after a lamb. If your ankle is weak and you're just not able for that situation. And that's really hard, because if you're an adult and you've done that kind of stuff your whole life and you've been independent and you've sorted out all these situations, it's a really hard thing to have to then adapt to this new reality. And that's kind of very much part of what we try to, like Prof said, walk the walk with people, of this constant adjustment and adaptation to what you can do versus what you could do before. And that is something we're totally conscious of all the time. Yeah.
So David, Dara's platform, that could help.
Yeah, so Dara Melrose is my name, so I'm a physiotherapist as well, and I've got the pleasure of supervising Arvel's project. And I think that when we are always looking at fall risk, and if you're not lucky enough to get into clinic to see Deirdre, we want to know what's happening at home. So that's the whole idea behind developing technologies that will be in your home, will be very unobtrusive, using little sensors that will track things like how your balance is progressing, is good, is bad, what situations you're in where you might be at risk of falling, that can be fed into the expert to give you the correct strategies to stop you falling. And the platform that we're trying to build, we hope, will be able to give you all those strategies, teach you at home, and give you the information that you need at the time that you need it, so that we can avoid falls, because they're absolutely, as Deirdre said, they can be catastrophic, so we want to avoid them at all costs. So we're really hoping that technologies and sensors will help in this regard down the line, and that's what we're planning to do with the platform we're building.
I think there was a glance at
Do you need it? There's a gentleman here.
All right. First of all, thank you for the great work you've done so far. My question is basically based on the clinical trials. How does it work? Is there some kind of selection process? How can someone get involved? I'm also want to ask about that finger testing thing is talked about. How can someone kind of get involved in it too? What are the processes? Are there anything involved? What can we do kind of to get involved in the trials? Thank you.
Clinical trials. The clinical trials have what we call inclusion criteria, and they're incomplete, or they're imperfect rather. The objective is to try and identify people who aren't moving too fast but not moving too slow, so that we can measure change and see if the change is slowed down by the drug. So every clinical trial that we do has a set of things that you have to have. A certain rate of progression, a certain length of time that you've had the disease. If you've had it too long, we're not allowed people to put people in trials. If it's so the selection of people in trials, we're very happy to talk to anybody who wants to join a trial, but in order for us to be able to put people into trials, we have to follow the rules of the trial, and they're different for each trial. And Niamh is the person who really helps to identify. So we're more than happy to discuss trials with people. That might what we call the selection criteria, the entry criteria, may change a little bit as we're trying to open up trials. At the moment, only 5 to 10% of people, only less than 5% of people get into trials, and some trials only have about 5 or 6% of people that would be eligible. So, for example, the Idaragon study that was approved. Only about 5% of people in Ireland would have been eligible for that study. So we're working hard in TriCast to try and improve the criteria so that we can get more people in trials at the individually. So, but at the moment they're quite tightly set. We are influencing pharma in that regard, but at the moment there are very specific criteria. In terms of Conor,
I just second what Prof said about the clinical trials, but for my device, our device, it's still very early stage, so anyone can volunteer. Anyone at all, we're just kind of in the heavy sort of data collection stage to prove how it works and to do like longitudinal tests, so like keep the same people at different time points over a long period of time. So we're always looking for people to volunteer for that. So you can just contact me afterwards or say to one of the clinicians at clinic and yeah.
Okay, just to say thank you very much to everyone for coming here today, to all of our speakers, to the Miranda students, to Leslie, Megan, Avril, Rory and David for helping me to organise today. It wouldn't have gone so well without your help, so thank you so much. All of the researchers are up towards the back corner of the room, available to answer all of your questions if you want to talk to them individually. Also, the aircon is a lot better up that side of the room, so I suggest you go for a little cool off because it is quite warm. We've one more question and they just say there's lots more tea and coffee there, so please drink it, eat the sandwiches, because if you do that, you're going to save my waistline. If not, it's up to me to finish the sandwiches and the cake. So thank you.
Thank you, Tracy. This may sound like a very selfish question, but I'm not really selfish. But of all the research that is being done at the moment, how much, if any, is relevant to PLS patients?
Yeah, it's a really good question. It's not a selfish question at all. You're right. PLS is a subgroup of motor neuron disease. We're pretty sure about that now. Actually, there is a big research program going on in PLS, run by one of my colleagues, Peter Bede, who works with us as well, and one of his students, Owen Finnegan, was working on that. There is a consortium for PLS, and we're members of that as well, to try and identify drugs that would work for that particular form of motor neuron disease, because it's a bit of an orphan. And motor neuron disease is an orphan disease, but PLS is an orphan within an orphan. So it's not that we don't. It's not that we don't care. I should mention as well, actually, that Bahman and Saroj and his group have also done some research. You probably participated in that in Bahman's PLS research as well, but we're happy to talk to you about that as well over tea and coffee. In terms of drugs for PLS, it's challenging. We don't have a set of drugs, but we're very keen to develop those. And actually, some of the work that Bahman is doing could be very useful because it could be an output or an outcome for some of the drug development that happens. So it's going to be quite important to work with Bahman is doing on PLS. Anyway, we are thinking about it.
Okay, I think that's it. So as I say, all the researchers are going to be up the back of the room if anyone wants to ask them any individual questions or look at their poster boards to learn a little bit more. So thank you. If I could just ask the speakers to all go outside onto the balcony for a photograph. Maeve has given me orders to tell you to do it.